We'll keep an eye on.
That's random.
Yeah, right.
Yeah, I think we would be, there might be a hook that came across the screen if we go too long.
Now I have to hit the button that says shut the meeting down. Well, people are coming in.
I was going to say, I know there's going to be more than that on here. So
Yeah, you can, if you want, just tell them to hang on. We'll be ready in a minute. Actually, it's 4:15, but we do have people still coming in.
Kristin's usually a real crowd getter.
Oh.
Because all those controversial things I say, right?
Uh-huh. Well, that's what we hear.
Yeah.
Yeah, Carol, I think you're right. It's like 5:20 because at 5:30 we have to go back to the MC room.
Right.
Okay. You have 31 participants. It is 4:15. If you want to get started, Kristin, that's on you. People can hear you and we're recording.
Right. Okay. Well, we'll go ahead and get started. I'm sure more will join in as we go, but good afternoon, everybody. This is our final session for our CPA conference 2020, Vision 2020. And we have with us this afternoon, Deputy Secretary Kristin Ahrens. And we thank you, Kristin. She's had a busy day, probably tired of talking. But so I'm going to hand it to you, Kristin. You tell me when to switch slides.
All right. Well, thanks so much, Carol. And thanks for all of you joining us this afternoon. You can go ahead to the first slide. So we'll have plenty of time for questions or discussion today. I'm going to go through sort of the overview of where we are in terms of COVID impact on our community. So I'll go through numbers that you've seen before, but the updated numbers. Do just some check-in on sort of where we are in terms of policy, talk a little bit. I also want to update everyone on the work that we're doing around racial equity, and then some of what we're seeing in terms of incident reporting. So with all that, I did a similar presentation earlier today. Should be ample time for question and answer and some discussion. So let me start here. This is the report we issue each week. This includes data up through through yesterday. And this is for our community programs. So anyone who's registered for services, including people in private ICFs, this does not include our state centers. State centers to date, our total is 10 residents of our state centers have had a positive COVID test. 12 staff have had positive COVID tests. Remarkably, the individuals, the residents in our state centers have remained asymptomatic, which I think for many of you have a sense of the population that's in our state centers, and it's just remarkable. I mean, this virus is strange and continues to surprise. I think we'll take it. Asymptomatic certainly works for us. So odd given age, odd given the number of comorbidities that most residents have, but that's where we are with state centers. In terms of community system to date, we have 1,310 reported positive cases of individuals in our system. You see that is still, the total number is very driven by what happened in the Southeast. Most of that pretty early on in the pandemic. We have had 126 deaths to date for people in our community system, our private ICFs. Again, you'll see primarily that was in the Southeast. The good news is that the rate of hospitalizations and the number of people that have passed away due to COVID has definitely declined. And I'll show you the hospitalization data in a minute, but In the past, more than the past month, we were having, many deaths per week up until then, and those have really dropped. So we hope that this trend continues to improve like this. Statewide, we've had 1,711 staff that have been reported as confirmed positive tests for COVID. Again, you'll see the numbers very driven by the Southeast. Okay, go ahead to the next slide. And these, you've seen these, this is updated. We update this weekly. I think the visual is helpful in sort of understanding the trajectory of COVID in our community. This is the weekly total of cases of individuals. Top line is individuals statewide. The line right below it in the beginning part of the chart is from the Southeast. So again, very much driving the statewide numbers. You can see toward, as we get to August and September, where we actually have areas where the West surpasses other regions in terms of number of positive cases. That coincided with, that jump in community spread that we had out West for a while. Next slide. And then this slide is the number of staff cases per week. And again, you see very closely follows Southeast in the beginning, and then at the beginning of July, when we were seeing high community spread in some Western counties, we saw that bump. That's the black line right below the overall state line. We saw that bump happening out West. You can see more recently, fairly similar numbers coming through in the different regions. You'll see a couple of data corrections in there. There's 1 week where we had negative number of staff cases in the Western region, and that was just a correction that a provider had submitted. I think we had double counted. So go ahead to the next one. The next one is another, this is just another way of looking at this. We wanted early on, as we would do our daily huddles, looking at all of the reported cases that were coming in by provider, but individuals, staff coming in. We definitely were seeing this pattern where you'd have a staff case and then you'd have individual cases from that. And you can see those numbers, the trend line kind of follows along. July is when the masking mandate went into place. And I think, finally we're at a place where we had pretty adequate supplies of this. And start to see some nice separation of those two lines. So we'll continue to watch this. I mean, I think, the science is there certainly supporting that masks help reduce spread. We now, as we're doing our meetings and looking at the positive cases coming in, we will see cases where a couple staff have it in a home and it isn't transmitted to individuals. Or the same number of staff even. So, I think certainly the more recent efforts, we're having more success with them in terms of mitigating spread, and that's what we want to see. Don't know what that bump is at the end of August. We'll certainly look into it. This is preliminary data, and we will certainly be doing work to understand it more deeply. But I think it's a nice visual for overview of kind of how this is trending. Next slide. All right, and then I've shared this one with you, but I've shared daily rates. At this point, we've gone on long enough. That's pretty visually overwhelming. So this is broken down on the top by week, on the bottom by month. So you can see we had weeks in March, April and May, very high numbers, number of weeks up in the 70s. We actually had a week, the very beginning of September, with 0 hospitalizations, which was amazing. I would love to tell you we were going to keep September at 2, but I'm pretty sure we had 3 hospitalizations this past week. So that will rise, but very much the trend we want to see. And I think, we're all certainly bracing for what we keep hearing may be another uptick or a surge coming through the fall as activities move indoor. Again, I think you know, looking at what's happening within the CPS facilities that have opened, the quick reaction, you know, the testing, the contact tracing, all of the activities to prevent spread to date have meant that facilities tend to be reporting one case, one staff person, one individual, and the activities to mitigate it are working, that we haven't had to date, knock on wood, an outbreak that came from a CPS facility. We have one we're watching very closely right now where there were 2 cases, and we'll see. But, you know, generally, I think the types of precautions, the routines and protocols we've gotten into definitely are working. We're watching community spread, and we're watching providers having some nice success keeping that out of their facilities. So kudos to all of you for what I know is an extraordinary effort to do that, and a constant level of vigilance to make sure that that we are doing everything we can to make sure that the people we're here to support are safe. So we'll keep sharing out the data, but those are some impressions from the data we have. All right, next slide. And something I want to alert you to, and I'm hoping some of you are familiar with this and have seen this, but the department, and if you haven't, please Google it, look at this, and you're going to want to look at this every week. The PA Department of Health has on their website, if you just Google early warning dashboard, early warning monitoring dashboard, Department of Health, Pennsylvania, you will find this dashboard. They update it every Friday. It has the spread, the case count per 100,000, and the positive PCR test rate. And that rate is important because it essentially says we're testing enough. We have a good picture of what's happening in our community and how much spread there is. So the kind of standards that if you look, the Department of Ed was, I think, the first one to kind of put out a standard of low, moderate, high, or substantial, and then guidance for school districts about what instructional models they should use based on all those. And the standards are less than 10 people per 100,000 and less than 5% PCR positivity rate as a low amount of community spread. Moderate, 10 to 100 people per 100,000 and 5 to 10% positive PCR rate. And then under substantial, 100 or more people per 100,000 and more than a 10% PCR rate. If you are already on this page, what you're going to see is there are places, we do have like Center County right now, would be considered substantial spread because of the very high number of students at Penn State, presumably. I know they just released numbers again for another group, I think maybe 200 more students or something. There was a large number that was added to Penn State. So this changes again. Every Friday, they update this number. You can get a look at what is happening in that area. Part of, I think, the value of looking at both the PCR and the number per capita is the number per capita could be driven by a single correctional facility outbreak, a single nursing facility outbreak. If you have a smaller county, the PCR rate kind of rounds out that picture of what's really happening in the whole community. So this should give you some good situational awareness for where you are operating services, help you think about if you do want to tighten up on any procedures or be having different conversations with individuals and families about the types of services or where you're providing those services. We're using this kind of framework. We will be releasing guidance on community participation supports around operational status based on whether your county is in low, moderate, or high. We're still working through that, but we will be providing guidance to CPS providers about how to think about the type of community spread that's happening. So please take a look at that. Next slide. The other thing, and you probably saw, I know there's been a big blitz around this, but I'll make a plug for it too. The Department of Health had been building an app that essentially it doesn't use location services. It works on Bluetooth, so phone to phone, chatting with each other. So if you're, you were in proximity to someone who then later tests positive, you will get an alert that you were exposed. Not going to tell you who it was and all of that, but it gives you an alert that you were exposed. Countries, if you've watched some of the countries that have had a high level of success with containing COVID, a number of them are using similar technology so that there is that kind of quick awareness for people so they can get tested, they can quarantine because they know they were exposed. The other thing this app does, and why it may be of interest to individuals and families, your staff, everyone, is that also you can look at that community spread right in the app. There's a feature in it where you can look at the data each week right from the app. It's got the symptom check-in on it. So a nice app, and I think the Department of Health went to great lengths to try to respect where we are culturally in terms of people's being all of the suspicions and mistrust around privacy, around this pandemic, around all of the invasions. I think people feel like, this public health crisis has created. I think the Department of Health has, with the programmers they worked with, tried to really account for all of that. So certainly, read up on that, but should be, could be, can be a very nice tool for us in trying to continue to manage this pandemic. All right, next slide. So I know I've mentioned this before. We're now doing it, so I'll give you the update there. We are doing an after action, after in quotes, because we are not after the pandemic. Usually organizations wait until whatever crisis they manage, whatever action is finished. We will likely do one when the pandemic is over as well, but we are in the midst of conducting the same type of after action review that you would do after a crisis. We're doing this with all stakeholders. So we currently have underway focus groups with individuals, families, supports coordinators, and AEs. So those are all separate focus groups that are currently being conducted to gather information about how communication, training, policies that we changed, guidelines we sent out, how all of those did or didn't work for people, how those were experienced in terms of them getting through this pandemic. The provider component of that we decided was too complex, and we wanted greater data than a focus group could provide us. So we developed a survey. We did work with our residential strategic thinking group to assist us with this. They both reviewed it and piloted it once we put the actual survey together. But it really gets into minutia about all of the types of regulatory suspensions that we did, the changes we made through Appendix K, some of the fiscal changes, prudent pay, the CARES Act, the retainers. So really goes through all of those different things that were put in place to try to help respond to the pandemic. I will be frank with you, the survey is long. So for a residential provider, this could very well take you an hour to complete the survey. You can go away and come back and complete it. Other types of providers, it should be much quicker. But I would really encourage you to take the time to provide the feedback. If you provide lots of services, pick the top two, your two, the two big ones that you provide. CPS is not included in this. CPS, we just made a pile of changes. We're going to want to see how those work out after a while. I think it's too soon to evaluate that. So that is not included. But residential, behavior support, employment, in-home and community, companion, all of those are included in the survey. It will give us a really good sense, I think, of what might have been a nice policy, but ODP, you didn't do a great job of communicating the parameters. You didn't do a great job of communicating it, so we weren't able to really use it, or this was the most critical thing in helping us manage. Here are things that we think we should continue post-pandemic. Here are some other things that would have been helpful that you didn't do. So we really want to do a concerted effort to get your feedback on what worked, what didn't work, what we want to continue, what we want to tweak, what we need to do a better job of operationalizing, because we have a long way to go before we're out of this pandemic. So if there are things, we have an opportunity now before the fall. If there are changes that we can make or other things we can do, we want to take that opportunity to do that. So please, I know you're probably survey fatigued. I understand you are completing them for everyone, for all the associations, for ANCOR, you know, for this is not the first one ODP has sent out. So no, I understand you are doing lots of surveys, but this one, it would be very, very helpful to get some good feedback on. So, and I hope you trust that we will use the information. I think the back and forth with providers about your challenges and what would be helpful. I mean, I hope you feel that we've been as responsive as we could be to that. I think it's the only way that we're going to get through this, and we're not done. So I hope we can continue that back and forth. All right. Question. Did I say that CPS is not included? Should CPS providers do this survey or wait for other services? CPS providers should not complete this survey. You wouldn't get very far in it because they'll ask you about the service and this is not listed. Just wait. We made so many changes with CPS 3 weeks ago. You won't be able to tell us if it worked or not yet, I think. So we're going to do CPS separately and find out how this last round of changes was helpful or not, and what else we might be able to do with CPS.
Kristen, one other question about that, if you mind. When these surveys do go out to the providers, are you expecting each provider to just do one version of it, like one person from each agency, or could multiple people fill them out?
So, you know, we are we are counting on your generosity. I mean, I think for a large, diverse organization, if you have really different, if you've got, you know, service locations in the Southeast, and you have service locations in, you know, Central region, you may have very different responses to that. And so, yes, it would be great if you could fill that out. Again, we'll take what we can get. And certainly I don't expect any provider to go through every service they offer and do that. But if your primary business is in-home and community, please take the time to complete that for us and let us know what the experience was. Otherwise, you know, again, pick your top two. And if you're a very large, diverse, you know, geographically spread organization, it'd be great if you could have, you know, somebody representing sort of the two different, multiple experiences or two different experiences do that.
Thanks.
Yep, thank you. All right, go ahead to the next one. So policy changes, this is just to kind of catalog and go through where we are with policy changes. So we are now at our third approved, you have a cat, Carol? Your cat's joining you.
Oh.
I'm sure you'll hear my dog bark soon.
Okay.
So we have 3 approved Appendix Ks that we have submitted. All of them we submitted for the full year that we could submit them. We are not anticipating at this time that we would withdraw any of those prior to March 2021, but you know, if this really turns around and we don't need those, then we would consider it. I'm not anticipating that at this point. So those are likely to stay in place. We do have an operational guide that is delayed getting out. I had hoped you would have that 3 weeks ago with the webinar that we did. It is still an executive review. I hope that it'll be out in the next 2 weeks. Meanwhile, if anybody doesn't have the PowerPoint, please check in with Carol. We tried to put a lot of the detail in the PowerPoint, and it should be enough for you to kind of move forward with some of those policy changes. That last Appendix K was, a lot of that was about the changes with community participation supports. The other set of changes that we have made and are probably lesser known to this group is through the what's called the 1135 authority. So these are things that actually had to be changed in our Medicaid state plan. So we had the ICF regs or federal regs. So we had to apply for modifications and suspensions through the federal government for those. We have those. We should have out. We've tried to make a translation document because what came back from CMS was pretty hard to follow. So we have that. I think we're close to publication on that. Other things like the rules around not doing redeterminations and keeping people on their Medicaid, that's all in those 1135s. The approval we have for electronic signatures, that's not something we do through the waivers, that is through the larger CMS authority. Us being able to use settings that don't comply with the settings rule for quarantine, like using an ATF or using something on a campus setting, all of those types of things, we have approval through the 1135 for that. And then the important thing to know about the 1135 is the time frame is different. The time frame for those are attached to the federal public health emergency, which currently goes through October. If that isn't extended for 90 days, those will expire. So we will definitely need to provide some additional instruction if the president doesn't renew the public health emergency status. So that did get renewed last time. There was some question about whether it would. They did it right before it expired. So I think we'll have to wait and see if that happens again. But certainly, particularly the electronic signatures right now, I think has been huge to keep wheels in motion. All right, next one, Carol. Okay, on the funding side, a couple weeks ago, I guess 2 weeks ago, you saw a whole blitz about direct care workers, $31 million of CARES Act funding being sent out to direct care workers for hazard pay. I want to be really clear that that was appropriated at the same time that the $260 million was appropriated for ODP. We got all of our funding. We were able to get out the door by the first week in July. Our funding stream is a lot simpler, I think, than OLTL. So this was the last of the disbursements of funding that they had been appropriated through Act 24. I know a number of you have been asking about the expense reporting for those funds. You should see the form and the instructions by early next week. I believe some of you saw Rick was doing kind of a preview of it, but that should be out next week. The actual online form itself for submission won't be available until October. But the form that you get will give you everything you need to know what you're going to need to put into the online form in October. So that is coming shortly.
Sorry, Kristin, before I forget, is there any possibility that the deadline for completing that form will be extended? That has been asked, a concern.
I don't expect that it would be. That deadline would not be, that would not be an ODP deadline. That would be a DHS deadline. And it's hard for me to imagine, given our time frame with the federal government, that DHS would extend that. But I can't say that for certain, but my guess would be no.
The concern is that the quick turnaround time. So the sooner that providers are able to get some information about how it's to be reported, the better.
Yeah.
They have time to.
And that's what you get early next week will really prepare you for the online form. I mean, you'll be able to respond to that online form with what you get next week.
Okay, thanks.
And then just to cover retainers, and again, I know I've probably talked about this, but just to make sure we're all on the same page with understanding of this, we are after September, so we did send out a communication last week about the CPS retainers for August and September. It does include the dates for when those gross adjustments will be made, and those should post to your accounts. Those are both 25% for both August and September. And that does now exhaust what we are able to do through our 1915C agreement with CMS. CMS in June sent out guidelines with the kind of guardrails that mean those are where the attestation rules came from. They also in that guidance said 3 30-day periods is the extent of what you can do. I do not anticipate that the federal government will be changing that rule. The series of rules that allowed them to produce that guidance make me think they have probably pushed that as far as they can. So I'm not anticipating CMS saying, you know, you've got additional time to do those retainers. To date, we have received 54% of CPS providers have submitted attestations and are getting payments for July. Rick will start processing the August payments soon. Actually, he probably is already processing them. At this point, those are going, those only go to that 54% of providers that have submitted those attestations. So if you need that communication we sent has the link for the attestations and the timelines for when all of those payments will be going out. All right, let's go ahead to the next one. Why don't I stop there? I'm going to talk about some of what we're seeing in incident reporting, and then I want to talk about the work we're doing on racial equity. But if there are other discussions or questions, things we want to talk about before I get to those two, now's probably a good time before we kind of shift focus. I do know if, I don't know if people are typing or not, I do know that there were, Carol had sent in some questions from members about some billing questions for members. We are putting out an FAQ. I know there were a number of questions around the planning and coordination billing, some questions about billing for remote services. We received enough of the same kinds of questions. I think we have a good sense of what people need in an FAQ. So I think we're pretty close on that. I saw a draft today that I think we can get out in the next week and a half, 2 weeks.
Okay, looks like.
Okay. All right, so one of the other things I want to draw everyone's attention to is we have, in looking at the daily reports that we get about sentinel events, about deaths, we have noticed that there seems to be an uptick in some of the things that we did that whole big push around about 2 years ago. So that whole big push we did around Fatal 4. We have, and we'll get more comprehensive data out related to this, but since July 1, we have had 53 choking incidents, 2 deaths that were associated with that. I can assure you that I'm sure some of those incidents were not avoidable. I am sure some of those incidents were absolutely preventable. And you know, I appreciate, I saw the survey that the provider associations published and put out. So I know, you know, in terms of turnover, in terms of vacancies, some of those struggles. I know that all focus has been on COVID and trying to keep in place, you know, all of these infection control procedures, doing staffing in ways you've never had to do or think about before. And the concern here is that all of this heavy focus on COVID means we have taken our eye off of some of the other things. And I'm not minimizing how difficult all of that is to do at once. I know that, but we have to do that. And so I'm urging all of you, take a look at your own data, go to your own incident reports, take a careful look. Take a look at where you are with your staff training. Take a look at your HRST if you're a residential provider. Where are you with the recommendations? Are you keeping those screenings up to date? We're going to do another push through the HICUs and kind of republish and put out all of those trainings. We had some, you know, some nice short trainings on the Fatal 4. We'll get those refreshed, get them back out just to raise the focus back on this, because not an area that we can take our eye off ever. And I think we know this, you know, years of watching how we sort of go through phases of just blanketing our field with this. We literally can never take our foot off the gas on this one. So please take a look. And review all of the work that you're doing around this. Not an area that we can take our eye. All right, and then the last thing I wanted to share with the group was that back after the murder of George Floyd, Isaac did agree that Isaac wanted to adopt a 14th recommendation to really enshrine that we would be doing some work around racial equity. Isaac members kind of looked around the room, well, virtually, but they know who sits at that table, and said, we can't do this. We shouldn't be the ones doing this work. We're not a diverse enough group of people to be doing this. Quickly decided that there should be a subcommittee, and that should represent the appropriate diversity to be doing this work. So that we have a work group that has been meeting quite regularly since then, drafted recommendation 14 to really enshrine that we'll be doing this work. Has started, you know, looking through the data. We're doing lots of detailed data analysis on everything from access to employment to restraints to abuse and neglect. So really kind of going through all of the major domains in our field to look at where we may have some disparities. The group, one of the first areas that the group really wants to take a look at, and we're gathering data, and I know had a provider earlier today say they're a large provider, they did a study and they have some nice data on their own workforce. So one of the things that came up that everyone seems to agree anecdotally is we have a workforce that is disproportionately made up of people who are Black and brown, and that doesn't necessarily carry through to leadership. It doesn't in organizations, in terms of a career ladder, it doesn't necessarily translate in terms of some of the more clinical professions. And so one of the things that the group decided is we want to, if anyone has these data, we want them. So we're, going to the University of Minnesota, going to the University of Delaware to see if there is really comprehensive data that will help us know what we suspect is true about our workforce, but we can't point to how real and what those disparities really are. So that's an area though that everyone agreed. We will be shocked if that isn't true. And I think having some data to help us understand the scope of the problem, we'll definitely be looking for some solutions to remedy remedy, particularly the career ladder issue. The other area that the group pretty quickly decided they wanted to look at is we have one, supports coordinators are required to do a cultural competency training. And the group wanted to know, you know, what is it? How good is it? Is it making a difference? Does it change people's interactions? Does it make them better at what they do? Does it help them actually better serve a diverse population? So we have the work group is doing some evaluation on that. And then we'll let the data drive, we'll let two things drive other strategies. So the work group will be reviewing all these data, but the work group also was very clear that data isn't enough, that there's lots of things the data won't tell us, and we have to talk to people. And so the work group is also designing some focus groups, surveys, different ways that we can gather information about people who otherwise really haven't had a voice in telling us how our system does or doesn't work. The work group proposed what you have on the slide as the recommendation, and Isaac essentially adopted it, but said, once we get all this feedback from other people in the community, we'll finalize it when we know this is right, and we can't know it's right until we do a little more work. So essentially the recommendation itself tries to get at a couple things. One, that workforce reference I made is that last sentence, the duty to ensure that racial diversity is promoted and supported at all levels within the service system, that should be embraced. Aims at not just excuse me, access to services, but actually the outcomes of services. And this is one that, interestingly, we did see. I think we found one area where this may be the case. When we're looking at our employment data and we look at it by race, we're about a point off. Our white participants are employed, well, pre-COVID, employed at 17%. Our Black working age participants employed at 16%. When we look at data on who has an employment outcome and who's getting an authorized service, our Black participants are receiving employment services at 51%, our white participants at 41%. And then translate that to who's getting jobs. And, you know, I already said general, all ages, all working age is 1% lower for youth. It is 2% lower for Black and 3% lower for any other race. So I think there we have an area where it looks like we are providing a significantly higher amount of employment service, and it is not resulting in the same outcome. So there's a lot we still need to understand about that before we try to think about what the strategy is, and if there's anything that that the data really isn't telling us. But those are the kinds of things that this group is really digging into and looking at to try to remedy. The last thing I'll say about this is, you know, one of the other things that Isaac has talked about and the work group has talked about is ODP is in a little bit of a unique position here in that people come to us and they may stay with us for a lifetime. We do all ages. So some of the things like the health disparities that the general population may experience by racial breakdown, we may actually have opportunities to intervene and change the course of that because people come to us so young in some cases. So that's where you see the reference to lifespan. So that's been a nice discussion with Isaac as well. So that's where we are with that work. It's, you know, it's work that we feel very urgently about, but it is the scope of it and the scale of it and trying to pinpoint the key areas where we need to be focusing our efforts is very much a long-term effort. Having the conversations and having the right conversations with the right people is going to take time. So I think we're all feeling like we want to do this now, and I think we all kind of keep stepping back and saying we have to do it right, and we have to be having the right conversations with the right people about it. So stay tuned on this. Definitely a lot more to come. And I think that's all I prepared.
Okay.
Right. So Karen is asking, what can providers do to help efforts to promote racial equity? So Karen, this is a great question. And one of the things that Isaac talked about was that we have a little bit of a parallel here, which is when the NPR did that whole expose on sexual violence, Isaac came back and said, you know, ODP can't solve this problem. Like, all of us have to be engaged in trying to do this work to prevent sexual violence. And so every Isaac member organization came back with an action plan. Isaac comes back to those. We look at those action plans. How are you doing? Are you tweaking anything? What can be shared? We think we're probably going to end up doing the same thing. I think for now, what I would suggest to any provider is understand if and where you have an issue. So when you look at HRST, are you seeing distinctions along racial lines? And some of the things that where we're going in terms of our analysis of all of our data is, we know that polypharmacy might be an issue based on race. We know that, employment, obviously an issue based on race if we look at the general population. Engagement with law enforcement, obviously, is an area. So, we went into our restraint data, our abuse data, our neglect data. So far, restraints, frankly, we restrain white participants at a higher rate than we do Black participants. So that, for statewide data, that didn't bear out to show anything in terms of restraint. And that was to our pleasant surprise that was the case. Abuse and neglect, I haven't gotten down into the weeds enough to understand what I'm looking at, so I can't give you an outcome there. But some of this would be to say, look at all of your incident data and see if you have any distinctions there. Take a look when you have situations. Is law enforcement sort of equally engaged along racial lines, or is there anything there that you need to be looking at? Look at your workforce. This was a provider earlier today did that. They looked at pay. They dug into all of their pay scales and did it along racial lines. And then it sounds like they also looked at their status, employee status, in terms of program specialists, all the way up the chain. So really doing that analysis, I think, of your own organization. The individuals and families on the work group that for racial equity. One of the meetings early on, there was a very intense discussion where people were sharing, it was a self-advocate sharing and then parent sharing. The years would go by before I had a therapist that looked like me or looked like my child, that I had a supports coordinator that looked like me or looked like my child. So a lot of people sort of sharing that they didn't have physicians, they didn't have behavior therapists, they didn't have speech therapists. So at that sort of end, just not experiencing that at all from the professional community. So I think there's a lot that we can do, but part of it is sort of situating yourself within that and figuring out how you sort of measure out compared to general public, how you measure out just along the racial lines within your own organization. And then I think just keep following along. RCPA is a member of Isaac and engaged in this. And I think as a ID community, we will be coming up with strategies that will involve all of the different stakeholders in those strategies. Thank you for asking.
Okay, we have time for some more questions. Until any of those come in, I did want to, I know because we talked a little bit right before this, that you're aware of the press release that went out, and the providers, all the 7 associations did do surveys of their members and ask questions about how COVID has been impacting their ability to operate services. And the bottom line is that the turnover is up, it's 55%. And providers are experiencing additional expenses with PPE and cleaning and less revenue because of the schedules and so forth. So there is an ask going to the legislature for additional funds. And, you know, we know a lot of people are going with their hands out. So
yeah, this is, you know, so many industries hit really, really hard.
right.
Yeah.
Right. So are there things, Kristin, that you think will be continued after COVID that were put in place now that will end up in policy changes? Do you have any?
Absolutely. I think some of the technology use and the switch to remote technology, I absolutely think we'll be keeping, you know, quite a bit of that in place as options. We'll learn a lot. We have a number of questions out there through the after action review that we'll get feedback on, but from our perspective, we absolutely want to just keep capitalizing on this. I think that we have historically, our population experiences such a massive technology gap, and by necessity, we have had to get technology into people's hands. We've had to be working with people to learn how to use that technology. Frankly, I think we need to be looking at that as, you know, the next for our employment providers and people who are interested in that world. I don't know what retail and restaurants, like how those businesses recover after this. We know that a lot of the people that come to us for services are in retail and restaurants. So are we helping to not only build skills where people can connect with friends and family and they can get instruction and learn how to do things like everybody else, and are we helping them build skills that they can use in a workplace that are going to be necessary in a workforce going forward? So I think those are the areas that I am very confident that we will look to continue, expand, refine, whatever that is. I don't think we should lose any of that going forward. I think operationally, some of the other things we're feeling, and again, it'd be interesting to hear provider perspective, but even doing the way we've been able to do licensing, either investigations of complaints or validation of plans of correction, or even we've been now using it for annual licensing inspections, using either remote only, some combination of remote and in-person. You know, I think all of those kinds of efficiencies are things that we would look to continue going forward. Some of the other ones, I think, you know, let's see how they play out, and certainly would want to hear from providers, and that's part of what the survey will do. I'd love to be able to continue letting people exceed the caps of our waivers, but I don't think that one's going to happen. So there's some of those that I think will just, they'll go away because we won't be able to continue those post-pandemic, but other ones where I think we will certainly look to build on.
Okay, that's good.
Yep.
The cap is definitely a hot topic for this fiscal year.
Well, this fiscal year, it shouldn't be. People can, if it's COVID related, they can exceed the PFDS or the community living waiver. We have to get, unless there's another extension after this K, the fiscal year 21-22, they will have to be within cap. So
2021, we're good.
yeah. We have that approved through March of 21. We can't let them exceed it and then somehow pull it back between then and June. But by July of 2021, people's plans will have to come back in line for that fiscal year. So yeah, people should be okay this year. As long as it is COVID related, people can exceed those caps.
That is a relief to, I'm sure,
Yeah.
to many.
Yeah.
Mine.
Yeah.
So even if they're exceeding it in April and May and June, they'll still be able to exceed it.
We presume that there will be people that will have exceeded it by March, and then
So they won't be cut off from service.
I'm not. Yeah, it's not like we can pull that back at that point. So yeah, it would just have to be for the next fiscal year.
Okay.
Yep. And we are sending out another communication on that, because I think people were there was some confusion about the limits around that. So there will be something going out very soon about the caps as well.
Good. Do you have another question? It's a long one.
I do. Regarding the modification to allow modified medication administration, why are providers being required to retrain employees in the full course who have gone through the modified course? These are staff considered qualified to give meds now under the modified, but will have to retrain them in the full course so they're qualified to give meds again. That doesn't seem to make sense. This is somewhat burdensome on agencies. So the modified med course was not designed for DSPs and licensed settings. It was designed for life sharing. It was designed for relatives. It is a very, very basic training. We allowed it during this time period because it's a pandemic and something is better than nothing. But really the gold standard is the full medication course. So that is why that decision was made. And I understand it's burdensome, but the modified med course was not designed for that other use.
Is there a time frame that people will have to complete that after?
Peg might know better than I do. I don't know.
Right. Do you know, Peg?
I'm sure we published something, which is why Peg's got this.
Well, I'm not sure there is something published. We had asked a question.
So we can, if you send it to me, Carol, we'll follow up with that. I don't know off the top of my head.
Okay. Yeah, if it's a year. Okay, I believe we were.
The deputy said, look at that. Carol was right. I believe we were told within 1 year after the date they passed the modified course. That sounds like something we would say.
Okay, so I'm just looking at some of the other questions that I know we've had recently. Chapter 6100 regs, and this sure threw a wrench in what was the projected plan. Where do you see us?
Yeah, it did. I think, you know, we were hoping we would have the regulatory compliance guidance out for public comment and, you know, be in a position where we had published or would be publishing that. The other big piece is EIM. It's possible that date might slip again, that we may have to push that back as well. So I don't have a clear answer. I can tell you right now, the regulatory compliance guidance is really far off schedule at this point. You see the number of documents that we're putting out and the guidance that we're having to sort of, you know, keep up with changes in the pandemic and get out. Those are many of the same staff people. So we just don't have the bandwidth to be working on that in the background, and can't imagine that providers would have the time to be doing public comment on what is slated to be a couple hundred pages of regulatory compliance guidance.
Yes,
so yeah, I don't have a time frame for how badly that has slipped, but that is definitely slipped. And the EIM, I fear, is hung up a little bit in other IT changes that may ultimately require us to bump some of those dates as well. So stay tuned on that. I don't have anything definitive, but I wouldn't be surprised.
With the EIM changes, someone had asked if eventually is the plan that if a provider has a EHR, that it will be able to communicate with EIM?
I don't think so.
Okay.
Not EIM as we know it today. No. So I don't know if that sounds like a lovely future.
Yeah.
But EIM right now, no.
Okay.
Yeah.
And speaking of E's, how about EVV? Is there any talk of it being, I know it needs federal movement if it's not to happen.
I've seen advocacy attempts to get the feds to bump the date. I can't say I've had any indication that that's a real possibility. I've seen advocacy letters about HCBS funding and making sure, I think that there's a couple of things that there seems to be pretty broad agreement on. One, that states without federal help, Pennsylvania is not the only state looking at the kind of hole in our budget that we are. All states have to balance our budgets. So, how do states actually recover from this? So I think, there's a lot of chatter about the fact that, without a federal package to assist states, no one's real sure how we get out of this or how quickly we get out of it. So that's one thing. The other thing is just a lot of work trying to get HCBS on the radar. You guys probably saw there was rapid testing that's getting deployed by the Department of Defense to nursing facilities and assisted living. And everybody's like, what about ICFs? What about HCBS? So there's a lot of effort to try to make sure that HCBS is on the radar as they're making decisions about potential packages going forward. So I see a lot of that work happening. I have no sense of how it will ultimately, if it will result in that help coming. But things like that rapid testing, the saliva test would be a game changer for us. We're talking with facilities that serve medically complex children. Those kids want to go to school, but they live in a facility with medically complex kids. Right. So boy, if you had that rapid testing ability, what a game changer that could be. Game changer, in terms of some of the activities that people are doing if they're living in our residential homes, admissions to our residential homes, all of it. It would be such a game changer. But I have questions. I have things to advocate for. I don't have answers.
Okay. I know our national organizations that we're members of are definitely, they're all collaborating too, which I think is
yes.
Right.
Yeah, there's the right messages are getting there. I just hope they're being heard among all of the need that's getting presented out there.
All right.
So,
okay. One more question, unless I don't see anybody else submitting right now. I think a great fear of CPS providers right now is a second wave coming in here, and of course that will impact all providers, but the ability for CPS providers to survive a second wave, I think, is a question of how that.
Yeah, so, the guidance that we'll be publishing next is based on those kind of that low, moderate, substantial operational guidance for CPS facilities. So if I have moderate spread, what might I do differently? Are there different precautions I'm going to take with certain individuals? Are there people that probably shouldn't be coming if there's moderate spread? So we'll be releasing that guidance. Providers should absolutely be paying attention to that, so what's happening where you support people. And the other thing is to please use all of those flexibilities that we have provided to round out and really offer a variety of ways for people to get CPS. I think being able to be fluid around people's needs, and I know remote doesn't work for everybody, but being able to do that, you know, the service in people's homes. So you've got that person that if there's moderate community spread, they really can't be coming into a facility, but can you get somebody into the house to give them something meaningful to do, give their family some relief. So I think it's, you know, please take advantage of those things we put in place. Think about it as a service that's probably going to have to be much more fluid than it used to be. So yes, this is where I hope between rapid testing, PPE availability, you know, tracing app, the contact tracing, the RICPs, that we can manage to keep this thing at bay, and everyone get their flu shots, please. Please get your flu shots.
Well, with that final thought, thank you so much for your time again today,
thank you.
Kristin. And please remember, participants, to fill out your evaluations, the overall evaluation, and please join us for the wrap-up session that's beginning in like 2 minutes or something with Richard. All right, thanks, Kristin.
All right, thanks everybody. All right, bye-bye.